Good afternoon, and thank you for inviting me here today to speak about dependence and sickle cell disease. My name is Dr. Michael Kelleher. I'm a consultant addiction psychiatrist specialising in the treatment of addictions. And today I'm going to talk to you about the interface between treating pain in sickle cell disease and dependence. So I've been around long enough in medicine to remember this slide. This was actually something given as a ruler back in the 90s when I was training in Ireland. And somebody came back from a conference in the United States where they said that pain was the fifth vital sign and it was being undertreated. And they presented people with things like this, where you'd rate your pain on a smiley face scale from no pain to severe pain. And the idea was that we would treat pain adequately. I think this probably came from a good place. I think because there were such fears in the 60s and 70s about people becoming dependent on opioids, and especially strong opioids, that sometimes people weren't adequately treated for pain, especially for acute pain. But I think where that ended up, particularly in the United States, was people ended up chronically treated with opioids for pain. And they became dependent on these drugs when it was no longer necessary. And so what we saw in the United States was a large increase in drug-related deaths over the late 90s and into the noughties, until they decided that we should look at restricting the amount of pain-relieving medication, and especially for those things that people were being treated chronically for pain. And it had moved from conditions such as cancerous pain and maybe pain for the treatment of sickle cell disease, but a movement of people being treated chronically with opioids for back pain and things like it, where there wasn't really any decent evidence base for the long-term prescribing of opioids. There certainly was an idea that this couldn't happen here within the NHS, and there were, generally speaking, two reasons given for this. One was that our medicine is free, so for most people, so there was no profit for individual doctors in prescribing opioid pain relief medication, so that won't be a driver to what they do. And secondly, there isn't advertising of medication in this country, so you don't have this whole public campaign in the same way. But nonetheless, we saw in the United Kingdom over the noughties an increase in the amount of people being prescribed opioid pain relief. And there were increasing concerns in Britain that there was too much opioid pain relief being prescribed. And with that in mind, the Conservative government, commissioned Public Health England, which I was National Clinical Advisor to in 2017, to do a review into dependence-forming medications that were prescribed. And that particularly focused, I think, on opioids. They were also looked at drugs known as gabapentinoids, and also looked at benzodiazepines, Z-drugs, and antidepressants. And this review was interesting, and our analysis showed that in 2017-2018, about 5.5 million adults, about 13% of the population, had been prescribed a strong opioid or an opioid within that year. And they went on to say that opioids have a role in short-term prescribing for acute pain, but non-opioid medications and other supports have often been overlooked. For most people with chronic non-cancer pain, opioids do not provide adequate clinical benefit when balanced against the risks of dependence and overdose, poisoning, and harms to others in the community. And this was really interesting, because what we're really saying there is that there isn't much evidence for the long-term prescribing of opioids for pain relief, other than the treatment of cancerous pain. But I think what was overlooked was sickle cell disease, another chronic condition where people have acute flare-ups of this disease, where opioids may be an appropriate use of medication in this setting. And I think what's become increasingly clear over recent years that perhaps this was an oversight on our behalf. And I think certainly there is a sense, and increasingly coming from the United States, that perhaps we missed something, that patients who had sickle cell disease sometimes needed opioids for their treatment, or other ones who had been prescribed opioids long-term for the treatment of sickle cell disease were now dependent. But because people had become obsessed, perhaps in an addictive paradigm, they were now being forced off their opioid pain-relieving medication, which they really struggled to cope with. From the study that I've shown there above, participants showed that in America that their opioid prescriptions had become more restrictive, so they were less able to get opioid prescriptions when they needed them. And they believe that their physician had an exclusive focus on reducing pain medication, resulting in further stigmatization and decreased attention to the patient's overall medical care. What became the most important thing was whether the patient was addicted or not whether they were being prescribed medication to cope with their sickle cell pain. And there was an emerging interest among adult patients in the consideration of the use of alternative therapies to manage pain. But in many cases, patients felt forced to pursue non-opioid approaches because of issues of access to opioids. So I think just to stop here for a minute, I think just to, In no sense am I saying that a patient should be prescribed long-term opioids for sickle cell pain if it can all be avoided. They need to look at other strategies. If we're going to give people opioids early on to treat their pain, we should look at means of tapering, getting them off them as quickly as is feasible. And that in many ways has benefits because it'll mean they won't have developed tolerance to the pain relieving effects. It means they're less likely to suffer from side effects like obviously constipation and nausea, but also things like hyperesthesia, becoming super sensitive to pain. Also suppression of the hypothalamic pituitary adrenal axis, so causing problems with sex hormones, and later days osteoporosis. So obviously we shouldn't, if we can at all avoid it, stay away from starting people on this medication. But we also have a group of patients who have been prescribed this medication for a long period of time, who have inadvertently or iatrogenically become dependent on opioids. And I think we need to treat them as humanely as possible. And sometimes the correct course of action won't be to force them off their medication. This particularly came to a head for me recently, 2 recent patients. And the first was a female patient in her mid-40s, and she recognized she was dependent on many different opioid medications, and she was struggling to reduce. And what she found was that people were asking her to come down too quickly. She was going into withdrawal. She was tending to bring the dose back up, and she felt, I guess in a way, coerced. And her whole focus was to come off. That's what she wanted to do, but she felt that people were pushing her to come down too quickly. And this patient has really struck in my mind. And then a male patient who was being prescribed pethidine. And because in a formula said pethidine can't be prescribed for the long-term treatment of pain, even though he'd been on it for 15 or 20 years, he felt he was being forced to choose other opioid pain relief where he felt this was the one that suited him best. And again, perhaps we wouldn't start from here in the sense that in an ideal world, neither of these 2 patients would be dependent on their opioid pain relief. But the reality is both these 2 patients were on opioids for more than 20 years, have been prescribed it chronically for more than 20 years. They recognized it was perhaps unhelpful to them in certain situations, but they really struggled to come off it, and they felt that they were being coerced towards certain situations or to being forced to come off. And if you look at this slide where they're looking at all drugs involved in opioid overdose deaths, they really started restricting access to prescription opioids in the States from about 2006-07. And if you look at this graph I'm showing you here, you can see that although opioid deaths are creeping up a bit, they're not going up astronomically. But towards 2013, 2014, drug-related deaths from opioids really took off. So although opioid-related deaths have doubled perhaps, which is significant, they really increased exponentially later on. And one of the concerns in America is that actually by coercing people who'd been made iatrogenically dependent on opioids, by coercing them off their treatment, they'd ended up turning to illicit markets to replace the feelings they got from opioids and their inability to live with the withdrawal features of coming off opioids. And I just think that's something that's really important to be aware of, that we can have unintended consequences to what we do. So again, making it clear, if at all we can avoid it early on, we shouldn't get people onto daily, regular doses of opioids. But if you've got a patient who's on treatment for a long time, the correct course of action might be to maintain them on that treatment and gradually reduce it, but not to be coercing people, forcing people to come off in a very short period of time. Every patient is different. When we look at opioid dependence in chronic pain cohorts, it's a heterogeneous group. Some people would say it's less than 1% are dependent. Some people would say it heads for 80%. It's hard to know. Tighter analysis would say perhaps a quarter of people would meet criteria for dependence who've been chronically prescribed opioids. But it is a complex field. And in a way, addiction is an arbitrary construct. And in this case, it will have a crossover with depression and low mood. Because nothing will improve your mood like an opioid. And that's why patients, and the bulk of my patients, use illicit heroin and more recently things like fentanyls. So I think we need to be aware of the mood elevating effects that opioids have. So there were a few things we thought about when we did the Public Health England review, a few recommendations that would make you think that your patient might be misusing their prescription of opioids. So things like taking more for a prescribed opioid or by a non-authorized route of administration, seeking to have a prescription refilled early, seeking other treatment, maybe for other sedative drugs, gabapentinoids, benzodiazepines and the like, taking another patient's medication, buying a lot of over-the-counter medication. But the thing I would say to you is patients don't become dependent on opioids overnight. You've been watching your patient like this for years, and you can't really suddenly turn around like that and say, oh, now you're an addict, now you're dependent, now I'm no longer going to treat you. You have a responsibility to the patient who you've been involved in their care for that length of time to ensure that we have a means of carrying on treatment. And if we need to reduce the treatment or control the treatment, we need to do it in a safe fashion. I'm just going to put these criteria up here for you to look at. I'm not going to go through them all. It's a list of 11 criteria, which is the DSM-5. This is the psychiatric manual. There's 2 psychiatric manuals used to make diagnoses. One is ICD-10 or 11 by the WHO, and the other is DSM-5, mainly used by the Americans. I've got the DSM-5 criteria up here, but you can read these, and usually looking at more than 2 criteria to reach criteria of dependence, and dependence divides up into mild, moderate, and severe against these criteria. Commonly, people think of the physical signs of dependence is increased tolerance, which is taking more of the same drug to get the same effect, or getting less of an effect when you take the same amount of the drug, and the other one being withdrawal. And withdrawal happens with opioids. Opioids suppress the adrenergic release from the brain. And so when you take an opioid away, essentially what you have is too much adrenaline. And so what you're seeing with them are all the signs of too much adrenaline. Their pupils are dilated, they're tachycardic, they're hypertensive, cold, clammy skin, sweating, nausea, vomiting, diarrhea, and symptoms like this. Obviously, the signs you want to watch for an overdose. Opioids work essentially they kill people by stopping them breathing. So watching out for oversedation at a period of time after they've taken their medication dose. If you're worried that someone's taken too much medication, it's important to ask them about oversedation within a few hours of taking their dose. If you are looking for support from your local addiction service, you can find them on the Frank website, Talk to Frank. The link is in the slide above. But you Google Talk to Frank or Frank into any of your computers, you'll find your local addiction service. Generally, if you're worried that someone's addicted, they should be willing to give you an opinion. They may not take over the prescribing of opioids from you. Often the most suitable course of action might be for the patient to keep a diary and then hold to the same dose of opioids they're on. If they're on many different opioids, you might look to consolidate onto a single opioid. So if they're taking, say, Sevrodol and Oromorph, you might seek to move them to Oromorph in their entirety or the other way, just so you can work it down in a structured fashion. Got to remember, many patients don't want to attend an addiction service. They don't see themselves in the same way. That doesn't mean that they've been prejudiced against by other addiction clients, but a lot of them just won't want to attend that service. So it may be that it's something that you do with the support of the addiction service, but you are the primary care physician. GP carries on the prescribing. I think it's important to remember that addiction services like yourselves are highly pressurized, and they may struggle to answer you as quickly as you like, but they definitely should give you opinion and give you some support. My last points to you is that this is complex. It's not an easy problem to deal with. Something I've said many times before, but I'll reiterate it again. If at all you can avoid the chronic prescribing of opioids, please do. Stop patients falling into this problem. But in those who have been on opioids for a long time, abrupt, arbitrary treatment decisions, cutting people off their opioids or forcing them to come off very rapidly, can actually be harmful towards them. And indeed, we do know that chronic prescribing of opioids is associated with increased mortality and morbidity, but forcing people off is equally associated with negative outcomes. And so within that, please be kind to your service users, be kind to your patients, understand they didn't intend to get there as much as you didn't intend for them to get here. But if you work with them in a collaborative fashion towards maintaining or gradually reducing or even coming off opioids, I think you will be repaid and it'll work for the benefit of your patients. Thank you very much.